I'll just wait a moment for people to join the webinar.
Okay.
Okay, let's go ahead and get started. Welcome everyone, and thank you for attending this Endo-ERN webinar. I'd like to thank our speaker today, Thomas Dan, and also obviously our MTG chairs, MTG3 chairs, for organizing this webinar. There's a great deal of interest, and we're excited to hear Thomas's presentation. My name is Amy Casey, and I'm the communication manager for Endo-ERN, and I just want to go through a few housekeeping items with you. We will take questions, but we take them at the end of the talk. So if you have a question, please pop it into the question box in your control panel, or if you prefer to ask the speaker directly, raise your hand and I'll unmute you. That will take place at the end of the presentation. In addition, I'm happy to tell you that this webinar is actually accredited by the European Accreditation Council for Continuing Medical Education. Within 24 hours, you'll receive an email from us that will have a survey in it. You'll need to complete that survey in order to receive your certificate. And if you have any questions, you can contact Endo-ERN directly through the website. Without further ado, I'm happy to turn the floor over to our MTG chair. The floor is yours, Felix. Thank you.
Yes, thank you, Amy. That's very kind. Hello, everybody. I'm pleased to introduce Professor Thomas Danne, who serves as the Chief Medical Officer International of Breakthrough T1D, previously known as GDRF. And additionally, he's also the Director Emeritus of the Department of General Pediatrics, Endocrinology, Diabetology, and Clinical Research at the Auf der Bult Hospital for Children and Adolescents. This is actually the site where I'm working at. So Thomas used to be my head in former times. Professor Danne trained at the Free University Berlin Children's Hospital and worked as a consultant pediatrician at the Charity Children's Hospital of Humboldt University in Berlin. He was a research fellow at the Joslin Diabetes Center of Harvard Medical School in Boston. And currently he chairs the SWEDE registry and served as vice chairman of the Endo-ERN consortium, which focuses on combating type 1 diabetes. He has held significant leadership roles, including Secretary General and President of the International Society for Pediatric and Adolescent Diabetes, ISBAND, and past President of the German Diabetes Association. Professor Danne's research focuses on pediatric diabetology, particularly disease-modifying therapies for type 1 diabetes, quality improvement through registries, and advancements in insulin delivery systems. Today, he will share insights on the SWEDE initiative, which was founded in Hannover, Germany. So please join me in welcoming Professor Danne. Thomas, the floor is yours.
Thank you very much, Felix, for those very nice words of introduction. And I hope some people will be able to join or listen in because I really believe that registries are so important to move the field of Endo-ERN forward. And so without further ado, here are my conflicts of interest. And as Felix already said, since April 1st, I left Hannover and I'm now serving as the Chief Medical Officer for Breakthrough T1D. I still have several conflicts of interest to tell you about. And one of my conflict is that very close to my heart is the MTG3 because for a long time before Felix took over together with Pietro, we worked on this, and it's something that we feel is very important. So what do I want to discuss with you? I will briefly talk about what other registries are there in Endo-ERN. I will tell you what my feeling is, why the data is so important. We'll let you in what the SWEDE registry is all about, then the role of rare diabetes in SWEDE, and tell you a little bit more about the difficulties of diagnosing rare diabetes around the world. And then finally, we open up a little bit the discussion what the possibility for new treatments are in particularly type 1 diabetes, but also rare diabetes, which may be interesting for rare diabetes as well. So what type of registries do we have? And there are basically, there's a website which shows you the registries for rare endocrine conditions. These are easy to find. Basically, there are two. The most important one for some causes is the EREC, where you can see that our glucose and insulin main thematic group has 330 children, for example, in there when this picture was taken. So when you're part of the Endo-ERN, you can submit your data there. And of course, it's important to show that you have quite a lot of data and expertise. What is very important for the EREC is there is no personal data in there. So it's more or less just counting the numbers here. The big advantage is that you don't need any informed consent form. The big problem, of course, is we don't know anything about capturing the same patient more than once. So if he's coming from Italy to Germany, then I'll put him in Hannover, and Peter will also put it in Italy. So the same patient may be there twice or without anybody noticing it. So there are always good and bad things about this. The big thing of the EREC is, of course, that we can see how many new cases of rare diabetes cases are actually diagnosed in different countries. And you can see here that for the MTG3, the genetic disorders of glucose and insulin homeostasis, there are quite a lot. In total, 1,170 centers were reported from 59 centers from 23 countries, among them 773 pediatric cases. So it's a good, well, spread basically around Europe. Some areas are a little bit stronger than others, but this shows how the Endo-ERN is working very well. Here you can see it's, well, there are others who are a little bit higher in numbers, better in reporting. There might be many reasons which we can discuss later why this is the case. But the good news there, well, is that the numbers also in our MTG are increasing in the last year. So how about the so-called core registry? This has more detailed and also longitudinal data. There are specific models, condition-specific models, of course. There are no rare diabetes modules for good reason, because to some degree, the suite registry, as I will show you, will be can perform this. And of course, we can see how we can practically work maybe a little bit closer together in the future here. So why is it so important to have data in diabetes? Well, we are always talking about big data. Everybody says, well, if we would have this big data, we could make great decisions, but really the reality is different. We are discussing about a digital or virtual diabetes clinic where an individual can upload their data in the cloud, and maybe even the artificial intelligence can then look at this data and make suggestions to the HCP, who then can have shared decision making with the person with diabetes, whether it's rare or not, to really come up with good suggestions how to go on here. And this might be the future. And obviously, through the COVID pandemic, many of those things have been already kind of accelerated, but still in many places it's quite difficult. And if we wouldn't have had such great young people who knew computers very well in Hanover, we would not have been able to have 5 different device softwares always running and putting it in a digital health record and so on, and always have the updates and so on, that we can really use it. So it's very much so that in the multidisciplinary team of the diabetes team, we now need an IT expert to make this work. And of course, for the data, it is always about data completion. How do we get all this in here? And yes, we realize that diabetes is a very heterogeneous disease, far beyond just talking about type 1 diabetes and type 2 diabetes, and particularly what is our theme today, the rare diabetes. We understand, yes, there are the genes, but then there are also epigenetic markers. There are many things which are beyond important for the biological variability. And to know all this, again, is then very important also to kind of make a diagnosis related treatment of this endotype of diabetes. And obviously, so any data we would have of whole populations and then would be able to identify the subgroups. This would make it so important to personalize the treatment, which, as we know, for many diseases is so important, and without any doubt, particularly for rare diabetes. So how could the SWEET registry play a role here, or what is the SWEET registry? And the SWEET registry was developed through the idea of the German diabetes registry called DPV that Reinhard Holl in Ulm has created many years ago. And you see that over the time, he has now 85,973 people with type 1 diabetes, but obviously also with all other forms of diabetes. But just here the numbers for type 1 diabetes, and you can see the good news is the data shows that the HbA1c as a measure of glycemic control is decreasing. The other good news is that the severe hypoglycemia is the most important acute hypoglycemia is also going down. Not so nice is that the level of diabetic ketoacidosis as the other big acute complication, there's not much of a change. And yes, all the new therapies that we are having are leading to more obesity. Whether this is just in the background population or as a problem of diabetes treatment is to be discussed. And you can see on this slide here that we have really a paradigm shift in the way that we're treating diabetes. So in 1995, when the registry started, most people had multiple daily injections and blood glucose monitoring for diabetes treatment. And this has completely changed now that we have automated insulin delivery. And it takes always a little bit of time before this really becomes the clinical standard. But you can see it is really increasing rapidly. Now, the idea was, why, if this works so well in Germany, why can't we do the same thing also in Europe? And we were very lucky that we were able to get many people interested, and particularly also in the European Union, which gave us some funding to put such a registry together. We also had some industry which supported this. And the idea behind it was that with benchmarking and looking at real-time data, real-world data, we would be able to harmonize care and thereby also optimizing the outcomes of children with diabetes worldwide. And ideally, of course, we would have to have equal high-quality care of children with diabetes around the world. We went to the European Parliament with the children, and we found a lot of support there as well. And just as these little children there on the left side are growing up and actually are growing taller than myself, also this registry has really grown a lot after 20 years. You see the map of 2023, how the number of centers around the world have increased. So on all continents, we are having centers right now that are submitting their data longitudinally to this registry with more than 1 million visits and more than 100,000 patients overall. And why do people submit their data? Well, simply because it helps them to manage their day-to-day clinics and that they can, on the basis of real data, analyze this data, set new targets, and then find out what to do. And it's not only about glycemic control. It can be anything. It could be the issue of complications. It can be the issue of obesity that you want to tackle. And you see always that over time, the right indicators tell you the completeness of data, so that really the completeness of data has improved over the time because people were interested, and then maybe for some things they were not so interested anymore. But this is all monitored and discussed in 2 annual meetings, and this helps kind of for every center to make an idea what they want to tackle in the next time, and what type of target they want to set themselves, and then ask also another center which might be better than them, how did you do it, how did you improve, what can we do to repeat what you have done. And since not everybody is good in every area, this is really an exchange of best practices. So is this successful? So we took centers that have been doing this for 10 years. And those are the 10 centers where we looked at 2008 and 2018. Of course, the number of people treated in those centers had increased. And what it shows you here is on the left, on the top is the type 1 diabetes exchange. That is a register in the United States, which had a very characteristic A1C curve, and they found actually the same A1C curve that they had in 2015 when they looked at this a couple of years later. Luckily, this was different and sweet. So somehow, by trying not to have select patients of each center, like the type 1 diabetes exchange, by trying to have basically nearly all of the patients of a center, we were able to see that there was a decrease, an improvement of HbA1c over the whole age span in pediatric diabetes. So you can also see that on a center level, just one center actually got worse. So there were some particular reasons for that, but most centers really had clear improvements in these 10 years, and they were, quite amazing in a couple of those centers. How about as glycemic control is not everything? You do see, if we look at the total data of all people that are now in the registry, well, of course, there are always new centers coming in, and they need some time. So the decrease of A1C is not as much as you would hope for, but yes, it is there. You see, there is quite a lot of decrease seen in diabetic ketoacidosis. Not so much, but particularly in hypoglycemia, as I've shown you before for the German data as well. We also are now using the continuous glucose monitoring data, because particularly in the time of COVID, not everybody was able to get an HbA1c, a blood measurement. So we look also at the digital ways that glucose is looked at, and we're calculating a CGI, basically a combined glucose indicator, whether somebody has HbA1c or has continuous glucose data. And again, there you can see that, yes, the centers are quite different. There are some centers which are extremely good on average. There are others who are doing not so well for all the good reasons. And you see here basically the average data of the group in Hanover. The good thing is it is improving over time, but it is, of course, also, well, there is still room for improvement. And the most recent guidelines for children with diabetes say that we actually want to look at even more ambitious targets of an A1C below 6.5, because we know that even with an A1C of 6.9, your cardiovascular risk is 3 times as big as in the background population. And obviously, everybody who has diabetes from early age on, like most people with rare diabetes forms, for example, very likely are particularly at risk, and they have the highest loss of healthy life years compared to their peers the earlier they get their diabetes. And then there are different scorings that are possible, which show you how much you are improving over time, and what is your overall score in the different age groups. Are you particularly good in the young ones, in the medium ones, in the old ones, even in the adult patients? So you have all this. So really collecting the data will give you a lot of food for thought, what you as a center maybe want to change. And then you can also compare, you see that with the diabetes technology, this is really an important driver for an improvement. And we know, for example, for neonatal diabetes, it's also a huge change since we're treating them with pumps. It's a huge improvement compared to the old days where neonatal diabetes was treated with injection therapy. And here you also see that the A1Cs in the pump patients are going down and down simply because glycemic control is better. And also we are getting more experienced in using this type of therapy. And probably the biggest driver of improvement next to the pumps is, of course, the continuous glucose monitoring. Of course, there are always big problems regarding the access to this. So there is no doubt that everybody agrees how important it is, but it is not so easy to get funding and reimbursement. But the good news, I think, if you see on a worldwide area, that those very, I should say, very ambitious centers that are participating in SWEET, 73% of the people which are treated in those centers of excellence, may I say that, have the ability to treat their people with diabetes with CGM. And the good news is, of course, we also look at the CGM data. You know that we have this the idea of time in range as maybe even a better outcome parameter than HbA1c, because it is not covering. You can see the basically also the swings, and that the A1c very often is not really reflecting what is going on. And so again, here we can say that there is an improvement from the first time we did this. There was still only 41% time in range and 6% time below range. So a lot of hypoglycemia. The target is below 4 for time below range, and above 70 for time in range. And yes, we're still not there with 70, but we are now there where the time below range should be. And you see there is a constant improvement. So I think with more technology, this will continue. And really the next big thing is, of course, the automated insulin delivery, those pumps. And you really see like a logarithmic curve starting here. We are waiting, of course, for the 2024 data, which will be presented next week at the SWEET meeting in connection with the ISPAT meeting in Lisbon, in Portugal. And ISPAD is the Society of Pediatric and Adolescent Diabetes, and let's see how this has improved from there. And already early data show that those who are having an automated insulin delivery pump are doing much better than those who have a pump without such a capability. And so already in 2016, the idea of having a worldwide diabetes registry was honored by the Prize of Innovation for pediatric diabetes by this society, and obviously all these people that are standing on the in front we're very, very happy there, because it's always a team effort when something like that becomes a big surprise and works out. Okay, so now let's move on to rare diabetes, because what I've shown you so far is, of course, the big numbers of the type 1 diabetes. And there's really a paradigm shift, because, you know, when I started going to med school, pediatric diabetes was all about type 1 diabetes, and we didn't really think too much about other forms of diabetes. Well, you know that in many areas of the world right now, type 2 diabetes is maybe even more important than type 1 diabetes. And we have learned more and more that, yes, there is also more than type 1 and type 2. If we should call it type 3, well, we can discuss it. Rare diabetes would be another way. Some people say monogenetic and atypical diabetes, whatever you call it, whether it's MODY or it's more the genetic thing. We have to acknowledge that the last 20 years have seen an increase in the prevalence and also the heterogeneity of diabetes in children and young people, and makes it more difficult to make a diagnosis. And if we now look into the SWEET database, you see that roughly 3%, with all these increasing numbers of patients in the registry, the proportion of those with rare diabetes always is around 3%. Interestingly, you see more of a rise in type 2 diabetes, but really the number of other types of diabetes is kind of pretty stable. And so it was, of course, a work then to look at what is it that we can see for characteristics in the different diagnoses that we have. You see, well, of course, type 1 diabetes was the most. So the other forms of diabetes are relatively small, and the majority of those in the registry were those with neonatal diabetes and the different forms of MODY. As a side, of course, also the cystic fibrosis-related diabetes, of course, was very important. But you see that there are many other rare diabetes forms, where there are only a few cases, less than those 45 that we have in there for the Wolfram syndrome. And it is quite interesting also to take a look at what was the age at diagnosis of different cases. So it is interesting that monogenetic diabetes forms like the MODY forms usually are diagnosed around 8 and 11, very much like type 1 diabetes, which shows how difficult it is to make the diagnosis, how it also takes some time in the lifespan of a person, so that those changes leading to MODY are actually clinically relevant. And obviously that those with diseases of the exocrine pancreas, that is not cystic fibrosis related diabetes, are actually the oldest age group here. The average A1C, I think the good news is it's pretty good. It's better than in type 1 diabetes with rare diabetes. So this is quite exceptional, I think. And it also shows that in neonatal diabetes, I think particularly because we have more and more people on insulin pumps, the outcomes here is also already pretty good. And there is really no indication that obesity, for example, is very frequent in rare diabetes. So let's have a deeper look how rare diabetes is diagnosed in Sweden. I also want to kind of encourage you, of course, to become a member of SWEET, but also once you are a member, use such data for clever ideas, what we can use and analyze and find out. And one of the things that is a big discussion is, of course, how do we diagnose diabetes, and how much makes it sense to use also genetic risk scores in addition. We know that it's important to have the diabetes antibodies for type 1 diabetes risk. There is now discussions to have also genetic signals for the diagnosis, obviously type 2 diabetes. We have even more genetic determinants, but of course, with monogenic diabetes, we have the highest degree of genetic determinants. But the question is, when do we use this in the practical life? So if I take this first 7-year-old boy who has 3 months of polyuria, polydipsia, and weight loss with ketones, well, you have type 1 diabetes and DKA. Well, you can already say, yeah, that's probably type 1 diabetes. Should you do antibodies? Should you do C-peptide? Both? Do you need a genetic risk score or a genetic diagnosis? Well, I think in this case, the antibodies were there. In 95% only of all people with type 1 diabetes at the time of diagnosis, we have antibodies, but nevertheless, when I was still in Hannover, we did antibodies in every child with newly diagnosed diabetes, and as something that I would really encourage. C-peptide is a different thing. It's not as well established as a parameter. I think it is very important, particularly if we are now looking of the more early times of the course of diabetes. You know about the stages that we're having in type 1 diabetes, the autoimmune type 1 diabetes, and obviously C-peptide as a measure of how much beta cells are still there is important for type 1, but maybe even for other forms of diabetes as well. But we need genetic testing? Probably not, because the most of them people have type 1, so it's maybe not necessary. But if we look at this person here, 16 years of age, a little bit overweight, African ethnicity, no typical symptoms of diabetes, occasional elevated glucose. What is this? If we look here, the antibodies, if they would be positive, then we would say with low C-peptide likely to be an early type 1 diabetes. If the C-peptide is still very high and there are antibodies there and there's only a little bit of dysglycemia, then this would be stage 2. If there are negative antibodies, of course, then we have to think, well, is this type 2 diabetes or is this rare diabetes? And there is, of course, now the question, are we just asking for the family history? Shall we immediately treat it as type 2 diabetes? Should we initialize genetic testing for MODY or do any other genetic risk score? There are very good clinical features that may indicate monogenic diabetes, and you can see them in textbooks, of course, when these are there, particularly clinical signs, you should, I think, initiate a genetic testing if this is available. So here, in this case that I have shared with you, now the question was, what shall we do here? Genetic risk score, yes or no? Well, it's like it could be type 2 diabetes, but of course we could also look for MODY. So this was now analyzed in suite on a more systematic way. How is this done in different centers? And 79 centers, 71 of them in high-income countries with taking care of more than 50,000 people with diabetes. We looked at how is the real world data collected to diagnose it, and you see that approximately 3/4, so the big majority had C-peptide measurement, but those having genetic testing, even for HLA typing, was a lot less. And yes, genetic testing in collection, also sometimes with some centers from different countries who were interested in getting those samples, was possible to some. But if we then look at the outcomes, those centers who had access to antibodies, access to genetic testing, they not only had a higher percentage of identifying monogenic diabetes in 54% compared to those with no access, and 70% to antibody testing, showing how important it is to have these different stages possible, to really have the antibody testing first, and then if the antibodies are negative, maybe continue to a more in-depth analysis whether this couldn't be a rare diabetes form of a different idea. So clearly it is the diagnosis, and anything that is in a database depends on the possibilities that we have in different centers. And I think this is also one of the tasks that the Endo-ERN needs to have to make it possible for all people in the network to have access to these diagnostic criteria, because only then we will be able to diagnose the rare diabetes forms adequately. So how do we collect the data in Sweden? Obviously, we have 2 deadlines. Twice yearly, everything is looked at. We are looking at the center level data to have the A1C standardized and are able to look at the average A1C. Then we have the patient level data. This would be where we would then actually also look at, when was it diagnosed, what was the presentation in onset, what was the A1C on onset, where the other chronic comorbidities. And then, of course, the therapy and the long-term outcome data on the very visit, because we want to have the longitudinal data, how the treatment course is happening over time. And then we, of course, for those with rare diabetes, we do have then the diabetes subtypes and the diabetes associated symptoms, which can be exactly put in so that we are able to identify how many of those rare diabetes forms are there. And obviously we know which center has individuals. Of course, we don't know any names because it's a anonymized way. So, but we do know that, I don't know, for example, insulin promoter factor problems are present in Zurich and in Berlin, something like that. And then when we want to do a study or want to look at this further, then obviously we can contact such centers and say, wouldn't you want to study this further? This is basically how it looks. So the way it is built up, and this is just now shown on a Excel sheet to give you the 3 levels of data. So we have, first of all, the center data level data, for example, what the standards in this center are. We have the patient level data, and then for every visit in the longitudinal time, we're following up things. So as you see, the next week, the ISPERT meeting is starting, and we have many new things that will be discussed. And I look forward to hear this. Obviously, I cannot share news prior to ISPERT, so it is important for you to become a member of ISPERT, and you can simply go to this website. You can use the email suiteproject@hka.de to get in touch and figure out how you might become a member, so that when the next annual meeting will happen in April 24 and 25 in Vienna, Austria, that you will be part of this meeting. And I think it's important for me to say a big thank you, as I'm no longer the chairman of SWEET, particularly to Michael Witsch, who is the mastermind behind all the benchmarking, or Kodanuri, who's now the head of SWEET, the SWEET coordination team, Tanja von Loh, Nicole Koller, and Katharina Klee, and last but certainly not least, the Ulm team of the endocrinologists led by Stephanie Lanzinger, and of course all the corporate members who are supporting this as well. So my final point now is, how do we make it to the future? And just if we take a look at the Wolfram syndrome, this is a little bit of a difficult part for Pietro and myself, because we tried very hard to actually do a therapeutic study of repurposing a drug for the treatment of Wolfram syndrome. We weren't really successful to get the funding. But generally, I think this is really one of the big advantages of the Endo-ERN, to also pull together all the resources in rare forms and looking for new treatments. And if we look at rare diabetes, of course, we have two different ways, basically, where the problem is, the insulin secretion defects and the insulin resistance problems. And the idea would be, at least for those with insulin secretion defect, maybe something is possible, which is really very much in the same way as we're doing it right now in type 1 diabetes. Because in type 1 diabetes, it becomes clear, yes, we have the diabetes technology, and it's a huge way forward. But even with a fully closed loop, the data in registries, the type 1 diabetes registry from the US has just shown that there is still hypoglycemia. There is still, because you have infusion set failure, there is still diabetic ketoacidosis. There are lots of device issues, skin problems. So clearly, even if we're going to, multi-hormone, even fully closed loop, where you don't have to do any meal announcements, it's not the ideal way. The ideal way would be, of course, replacing those cells that are secreting insulin, and maybe changing them through encapsulation or gene editing, so that no immune suppression would be necessary. And I just want to show you that this is really something that fascinates me a lot, and this is where I work a lot in my new position, that with the differentiation of stem cells into insulin-producing cells, we are really making huge steps forward. And those insulin-producing cells can now be produced, and we're no longer dependent on the cadaveric islets, because we can now produce those cells. And the biggest company so far appears to be Vertex, who already have now a big program, and they say they have now a good way, a pathway to making this happen. Right now, with the fully differentiated cells with standard immunosuppression, but maybe they just started to have them in a device, an encapsulation device. But as the next step, they hope also to have hypoimmune cells to treat this. And they made it at least 2 years ago or 3 years ago on the side of the New York Times, which is not too bad, because this individual did not need any further exogenous insulin, because with these islet cells plus immunosuppression, he was no longer needing exogenous insulin. And just very recently at the ADA meeting in June, 12 participants were shown. 11 of these 12 had a reduction or elimination of exogenous insulin at the most recent visit. The one person who did not had used steroids in the time when there was the engraftment of the cells. So we have a good idea why this didn't work so well as it would work in the others. And the most recent data is still going in this direction. And here you see how nicely the time and range above 95%, that's just as good as most other people probably also have. So it's really moving forward quite a lot. And just a couple of days ago, another group of China showed another example where an individual was no longer needing exogenous insulin. And this were with chemical reproduced, programmed own cells that were then put into the abdomen and also worked very, very well. So there are many things that are happening. And there are even gene therapies that are tested, very interesting. Two different vectors, one for the expression of insulin, one for glucokinase in the skeletal muscle. It worked in an animal model already very well, and they're about to start even human trials. So I think I can see that things like that would also be possible, particularly trying to find new ways for treating rare diabetes. So I really think we can. The future is bright, but we have to work together because yes, rare diabetes is rare, and actually type 1 diabetes is also relatively rare. But to really be sure that the balance between benefit and risk is okay. I think we need registry data, longitudinal clinical data, to be able to really look at this therapeutic paradigm change that is currently happening. And so I hope I have told you a little bit. I'm happy now to answer any questions, and thank you very much for your attention. And I hope that we don't only have to work in the US with the politicians there to make things happen, but you will help us also to join around Europe to make that happen as well, because I think this is a global thing that should be changed. And our organization, Breakthrough T1D, is now in the process of opening a large European initiative as well, because we really want to change the way diabetes is treated around the world. Thank you very much for your attention. Anybody out there? I don't see in the chat any questions. Felix, have you seen something? Pietro?
No, I think there are no questions until now. But maybe I can start with one. Thank you, Thomas. That was a beautiful talk and something like a psycho thriller through the journey of the importance of registries. It was really, really good. I was wondering, you talked about the COVID-19 situation, and I mean, the COVID-19 pandemic has had significantly impacted healthcare worldwide. Has the pandemic had a specific influence on rare forms of diabetes or disorders of glucose or insulin metabolism? Or is there any information that the Sweet Initiative has been able to provide any data or insights on this issue? Is there anything we know about the situation for rare diabetes?
I think all we know is the situation in type 1 diabetes, and it appears a little bit as if those who are susceptible for type 1 diabetes, so autoimmune diabetes, they had an increase in their incidence of type 1 diabetes, and it appears to be like a temporary increase. That actually kind of the virus situation led to, in those who were susceptible, they were more likely to have it at that time when COVID was there. And right now we have kind of the downswing. So many centers are reporting that they are having less diabetes cases than before. But this is still, I think, very much discussed. I'm telling you a little bit more what my feeling is, what the answer is going to be in the end of the day. And it might be regionally very, very different. But I'm not aware of anyone who has looked at what happened with rare diabetes. I think it should not have any, because those are monogenetic diabetes cases. Why should they be influenced by viruses? But I don't know.
I mean, there is an impact on type 1 diabetes, there is an impact on obesity, there's an impact on type 2 diabetes. So all these are glucose metabolic disorders. And so it might be that there also has been an impact or a change or influence or whatever on rare diabetes forms as well. But
But you
okay,
could see
it's good to know that there's something for research still
there's something for
possible.
research. And I think the interesting part also in rare diabetes is that on average, you don't see any increase in BMI. So the rare diabetes cases compared to type 1, where we do have more obesity and obviously type 2. But in rare diabetes, it's apparently not so much the case. For what reason whatsoever?
Okay, perfect.
Um,
May I ask another question?
Petro was also answering, but
please, Felix, I have another one later. No problem.
Oh,
Go ahead.
sorry, Pietro. I haven't seen you. You were Pietro. I did had you. Sorry, Pietro. Go first. I go after you.
Oh, just a general question about registries, but you are an expert, Thomas. You presented the SWEET registry, but you know very well also the Endo-ERN registry. So you talk about both, and I wonder what you think about the future of these registries, and in particular about the possibility that professionals try to save time because it's difficult the activity to keep registries active. So I wonder if it would be possible one day that when you put the data in one registry, you can connect that data with that of another registries in order that maybe may happen that some patients that are in a SWEET registry that are we know European patients with rare diabetes disorders might feed the Endo-ERN registries, and also the opposite. The patients that are in Endo-ERN might be helpful for the SWEET registry. So, what do you think about this this problem related to registries, and how we can think about the solution to keep all the data available for professionals and for patients as well?
Yeah. So number one, the biggest problem of registries is the financing of the registries. And I think the only way to solve this issue is to join the registry to different therapeutic pathways, which if you are using a certain therapeutic drug, the post-marketing study makes it necessary for you to actually show the data, very much like we have it in cancer. And I think I always like the idea that we shall do the more or less rare diabetes forms, which includes type 1 diabetes with the different stages, should be done in protocols where we have personalized medicine, where we have the genetic endotypes, and this can include, of course, rare diabetes forms. And depending on the endotype that you have, you will be treated with an autoimmune treatment, with adjunct therapy, with a GLP-1 agonist, with a SGLT2 inhibitor, with insulin glucagon, with insulin GLP-1, whatever. And then you need registry data to prove to the authorities that you're doing good things. Or in the end of the day, you have much more hypoglycemia and very high costs or whatever, like it is in cancer therapy. So I think this has to be the way forward, but it's a big thing. Everybody is talking about registries, but nobody wants to pay for them.
Thank you.
It's always about money. Yeah.
But you're very good in getting money, Felix.
Yeah, I still can improve. I think there's some space to get more to fulfill other projects. One last question, Thomas. As we from the Endo-ERN, we're currently we're working to gain a better understanding of the transition phase for patients with rare forms of rare diseases, rare endocrine disease, and especially rare forms of diabetes and associated conditions. Does the SWEET registry provide any data or insights on this transition from pediatric to adult care, particularly for rare diabetes forms? And is there
Well,
a space for contribution or collaboration?
so this is different from country to country. There are some centers where, or some countries where you have kind of in a center both adult as well as pediatric patients. So there are also some adult patients involved in SWEET, but the majority is the pediatric patients. And so obviously they are then lost. So all we can say is when are they lost to follow-up? Again, I think we really have to work to change the way that we are delivering care, particularly the separation of adult and pediatric diabetology for the intensified insulin or diabetes therapies, which includes rare diabetes, type 1 diabetes. I think we should leave because the knowledge with all these new therapies, with immunotherapies, with the insulin pumps, make a completely new diabetologist and a new training necessary. I always like to coin the phrase of the interventional diabetologist, like we're having interventional radiologists and interventional cardiologists. We need interventional diabetologists, and they know about the immunotherapies, they know how to treat a rare diabetes, they know how to do an islet transplantation, and so on, so that it is attractive also to the young people to go in this area. This is my dream.
That it is a nice perspective for the future about
Yes.
intensive care, yeah, that's beautiful. A question about the SWEET registry again. Probably I miss some slides, but is it possible for patients or families to upload directly the data in a SWEET registry or not?
No. So it is a center-based registry. It's not a country, it's not an individual, it's always a center that is in charge, because the basic idea is this data is uploaded to do benchmarking, to compare your data with previous data and with others to figure out ways that you can improve.
Okay. Because some
Okay.
registries gave a possibility for patients or families to upload in order to have much more data available, or at least patients and families that say, okay, I'm here, I'm available for you just in case you want to recruit new patients for protocols, or this is interesting.
So we just started to have patient-related outcomes that can be actually uploaded from the patient to make a change here.
Okay.
Yeah.
Thank you.
Okay. One last question, Thomas. It's a little funny, a little bit humorous. I mean, because I think we're all about imaging and so on. After all these incredible advancements and challenges, let me ask, if SWEET could have a mascot to represent its mission, what would it be? A pancreas in a superhero cape, or I don't know, a glucose molecule with a magnifying glass, or an insulin pump with a mind of its own, or what do you think? What's the best mascot for the mission
It
of
would be
SWEET?
the ant, because the ant is able to carry a lot, although it is very small. And I think it's about many people who are working together to make something work, and each of them is carrying a big load, but is doing very well. So I think the ant would be the right animal.
Okay,
And
the
very
SWEET
well
ant.
organized. And very well organized. So great idea.
Perfect. Thank you. Thank you, Thomas. Thank you very much. There still are no questions in the chat, so I think if there's Pietro, if you don't have any more to
I'm
contribute.
fine. I'm fine. Thank you. It was a beautiful presentation by Thomas. So you introduced very well, Felix, your previous boss. So thank you, thank you, Thomas, and thank you, Felix, for replacing Thomas in MTG free group.
I'll do my very best.
Yes, for this activity.
Keep up the good work.
Thank you. Thank you.
Okay.
Thank you, Pedro.
Thank you all.
Bye-bye.
Take care and see you soon. Bye-bye.
Bye bye. Thank you. Bye.
Bye.